So I think what's important to note is that in 2023, the AUA and SUO came out with the first ever guidelines on upper tract urothelial carcinoma. And to me, one of the real interesting parts and that really helps us in our practice is that it allows us to risk stratify patients. So I will open this up to anybody who wants to kind of talk about that overall risk stratification between low risk and high risk upper tract urothelial.
Yeah, well, I think I'll just start. I mean, I think that the guidelines, it's really helpful to think about that, and it's what we do already, right? When we think about urine cytology, high grade, low grade, and thinking about how do we address patients, but to be able to categorize that and give everybody guidelines, especially community urologists, I think is really helpful. So when we think about low risk, high risk, and within those, there's favorable and unfavorable, and then within high risk, favorable and unfavorable, and then allows us to think, what are options for them? And endoscopic management, nephroureterectomy, intracavitary therapy, and how do we drive patients toward those decisions? So I'll just comment on a global scale. I think that's really helpful for people, and it's good for people who, especially people who don't do upper tract every day, to be able to know sort of how to guide their patients.
Yeah, absolutely. I think just to kind of echo what Adam said, when you're dealing with a very complex disease process, just creating these risk categories kind of help you think about things in a more structured way. And it really helps also with education, teaching our students, residents, fellow, when you have some sort of guidance, it's really, really helpful. And also when you're creating guidelines, you do have to risk stratify to kind of categorize people. Otherwise, you can't really create guidelines without that.
Sure. Yeah, I think it's interesting also personally for, patients. When you're telling a patient you're low risk at progressing to invasive disease or you're high risk to progress to invasive disease, it becomes more meaningful, right? And then it makes the treatments, whether they be, ablative type of therapies or more aggressive with systemic therapies, followed by, bigger surgeries, it makes more sense to patients. Do you find the same thing?
Yeah, I think it's put it in terms that patient can understand, and it's also helped me, explain to patient why they need certain diagnostic procedure. So, I explain to every patient we have to make sure that we know what's the right diagnosis is. Right. Are you low risk? Are you high risk? Because that's going to put you on the path for the rest of your management decisions and surveillance.
Sure.
One other thing I'll say is, if you think about NCCN guidelines, upper tract urothelial was always buried within bladder cancer, right? Yeah. What's not even named urothelial. Same with urethral, and so the fact that we now have specifically upper tract urothelial cancer guidelines raises the prominence of what is a less common type of version of urothelial cancer, and raises the level of discussion and research and everything that we're doing. So leading to things like this. So I think that was really important to put it into the spotlight.
Yeah. I mean, obviously, as a medical oncologist, right, it's a little bit different in where you kind of play into this with NCCN guidelines and other guidelines, but obviously, I get the pleasure to work with you, on a regular basis. But any impact for you from a medical oncology standpoint of guiding urologists of when to send the patient to a medical oncologist for neoadjuvant or adjuvant therapy?
Yeah, I mean, maybe because I talked to you and the other surgeons probably more than I talked to most of the medical oncologists in my practice. I think that's probably, and honestly, that's the way it probably should be. The AUA guidelines, I think, are extremely helpful even for medical oncologists. Like you said, the NCCN guidelines, it's still upper tract is buried in there. It's not histology based, and even it's even less, I think, defined than AUA on even neoadjuvant chemotherapy. It's just like an asterisk in there that says can consider in certain circumstances versus I think AUA lays it out a little bit more. For when when I see a patient, Katie, I'm happy to see any patient you send, number one. But definitely something that's high risk, high grade is always a discussion of whether or not chemotherapy, neoadjuvant chemotherapy is a good choice. And if someone is, I think, cisplatin ineligible, has a high risk tumor, and you certainly see on the imaging that it looks large, and I think the discussion is something that should be had, and I absolutely give it if they're eligible. And another thing is, which is fantastic, it's written into the guidelines, is that having to take into account what their postoperative renal function could be.
Right.
And if it's going to drop, it better get that platinum in before.
Sure. Yeah, I think, something else that really, focuses on this multidisciplinary need for upper tract urothelial is that's written into the guidelines now is about hereditary diseases, right? With the most important, of course, being Lynch syndrome, right? We're talking about upper tract urothelial carcinoma and what that testing might look like. And, I think that it very much has that focus, but what are you doing in your practice, Dr. Truong?
Yeah, so what what the guideline now say is that every patient with upper tract urothelial carcinoma should have universal tumor testing for their upper tract cancer, which is pathologists have already been doing it. They do it universally for colorectal cancer and endometrial cancer, which is a much more common disease, much more common cancer, and the incidence of Lynch syndrome endo disease is actually much less than in upper tract cancer. So, for instance, the incidence of Lynch in colorectal cancer, when you actually test it, is about 2 to 3%, and the incidence of Lynch in endometrial cancer, when you test it, is about 2 to 5%. Versus in upper tract, you're talking about 5 to 9%. So at Penn State, we were able to work with the pathologists and approaching 100% tumor testing for upper tract cancer. So that's either with immunohistochemical staining for mismatch repair deficiency protein, which is MSS2, MSS6, PMS2, and MLH1. Or, they can also stain for next generation sequencing to look for microsatellite instability. And if they have mismatch repair deficient, or if they have microsatellite instability height, then they get referred to the cancer genetics team for confirmatory germline testing.
Yeah, I think that's really amazing that you've done that. So congratulations on working with your pathologist.
And the MSI testing, is that reflex also in addition to the IHC?
If they cannot do IHC staining, and if we have tissue, then we can stain for the Foundation One medicines, or any of the tumor profiling. They'll give you a tumor mutation burden, and they'll give you a microsatellite status.
That's great.
Yeah.